meeting of the year of the Compliance Committee of the Hospital Authority Board, and ask Mr. Harvey to read our mission statement and vision.
Nashville General Hospital mission statement: to improve the health and wellness of Nashville by providing equitable access to coordinated patient-centered care, supporting tomorrow's caregivers, and translating science into clinical practice. The vision statement: leader in exceptional community health care, one neighbor at a time.
Thank you, sir. And at this time, I'll give an opportunity for the members to state if there are any conflicts of interest regarding things being brought up in this meeting. If none, do we have any public comment?
No, sir.
Thank you. So we'll move on to new business. Purpose of committee, and basically this is a bylaws committee that has not met regularly for some time, and so we're sort of reconvening it to mainly keep the board aware of issues that are being very well taken care of, a lot of attention paid, but behind the scenes. But as in our role of overseeing the operation of the hospital, I think it's important for us to look at all the things that we're going to look today, and I think you'll be very pleased to see all the work that Christy and their teams are doing. Any other comments, Ms. Lewis? Okay, thank you. So we go to the standing reports. The first one is information technology and security. And Ms. Thomas and Mr. Leffler.
Go to the next slide. Good afternoon. Just want to talk about the things that Nashville General Hospital does, and then we'll talk a little bit about how we accomplish that. So first and foremost, there are access controls, vulnerability management. There's some audits that we do. First and foremost, we have multi-factor authentication for a lot of our sensitive data. We don't have any off-site connectivity without a VPN or multi-factor authentication. That comes in the form of a partner that would ping us or ping someone and verify through a text or something like you do at the bank. We have in-person verification, which is very strict if somebody needs a password reset. And then we do role-based access controls for our electronic medical records. So that is not giving it based on who you are, but what job you do. So a nurse would have access to the things that nurses have. The IT professional would have access to things that are an IT professional would have. And it's not based on what we pick up along the way as we support different roles. The vulnerability management, we use managed security services provider to scan our network. We have another backup with the CISA, with the Cybersecurity Infrastructure Security Agency, that also does scans. We patch our desktops daily. We have servers that are patched monthly, and we'll have downtimes on a regular basis, and you'll see that we're doing patches during those times. We're also patching our network as well. For cybersecurity awareness, we use a top-tier provider to do some of our training, so it's not just things that we have owned in-house that we have created. As a national organization that we work with to put the training content together. And then our users are assigned training at least twice a year. And then there's some random things that come out. If they happen to click on one of the tests that we send out, we'll give them refresher training as well. And so on those simulated phishing campaigns, if you bypass it, and I have users in this organization who do a great job of identifying that, They don't have to do extra training, but if you happen to click or open or do something you're not supposed to do, then they will put you immediately in remediation training. Next slide. We do our HIPAA risk assessment on an annual basis. 100% of our Cerner users are assigned based on roles. That's something new because when we were in our old system, we basically said, well, Melanie Thomas did this. Well, oh, she needs this. And we kept giving people access based on what they were doing for that day. And then if she left or they left and somebody else got put in that position, they'd have all the same access that person needed, whether they needed it or not. So as we moved to Cerner, we went to 100% role-based users so that only the access that they need, they get. We have a Microsoft security score of 76.14%. Similar size organizations are around the 50% mark. So we are doing more than what other people are doing. And this is what our Microsoft engagement people have told us and shared with us. Year to date, 51% of our users have completed cybersecurity training. This is a new program for us, so we are definitely trying to get that score higher where everybody sees it, they're engaging in it, they know why we're doing it, but this is definitely an improvement. When we started, we were probably, and when Andy came on board, we were probably at about 25% of our users had done something, and we weren't doing it as consistently as we're doing now that he's here. 87.26 of our devices are encrypted so that if something were to happen, if they lost the device or anything like that, we could wipe it, and then any PHI or protected health information would be wiped from that computer. And then we have endpoint protection on all of our computers. Do I have another slide? So in a nutshell, these are just some of the things that we do quickly. We also do audits on our users to make sure that they are accessing the patients that they are supposed to access. We are moving to a point where we're just doing 2 random audits twice a year, but we do quite frequently get audits where people have asked to have their access audited, or we might have a situation where somebody suspects that that a user has gotten into our accounts incorrectly, and we'll go and audit that. So are there any questions?
I have one, I guess it's 2 parts. The year-to-date users completed cybersecurity training. Is that something you guys started this year?
We started a couple of years ago, but it was very inconsistent. So we engaged with our vendor maybe about 2.5 years ago. We immediately pushed out a campaign, and everybody in the organization got that campaign on the same day, and everybody's like, oh no, what's happening? And so we did one other after that, but we are doing it much more consistently for the last year. So about a year ago, when our information security director was hired, he started doing more regularly scheduled campaigns. And so we push it out to every user in the organization. And we have some users that are on their computers quite often, and others that are engaging in their computers just to go directly into Cerner. So the people on the 11th floor, the people in finance, the people in HR, they're the ones that we're seeing that are getting on there regularly. We have to have a better strategy for the people who are not owners of their own device, and they're getting on that shared device.
Okay. And then the second part is the 87.26% of devices are encrypted. What's that 12.74% made of?
Yeah, so we, in the last 2 years, as we've been doing the Cerner implementation, have replaced a large amount of our PCs. What you see represented there a lot is some of the older PCs that are planning to be replaced. So we had computers as old as 7 and 10 years old here. Those were the ones that were not there. So as we started replacing them, we will get to 100% pretty quickly with that.
Thank you.
All right.
Any other questions for Ms. Thomas? We met last week and went over a lot of this in more detail. And so there's lots there. There's a lot of work being done. You all know there's been a security breach in the fairly recent past, and we approve a lot of requests for funds for software, and this is where it all goes in and is paying off. So I thought the board should hear some of the details of what's going on. Anything further from Mr. Leffler? Any other comments? Okay.
Thank you.
Thank you very much. We'll move on to auditing and monitoring. Yasmin?
Hello. What was it? So apparently mine's not going to, I guess it's in a packet that everyone has. So we, in the HIM department, complete monthly coding accuracy audits. So just the summary of those audits that we have completed for the quarter three. Our overall coding accuracy for quarter three was 96%. The target is to be at 95% or greater. There were a few key risks identified with pertaining to modifier usage in outpatient encounters. Our audit consisted of 250 encounters audited. 150 of those were inpatient, and then 100 were outpatient/professional claims. We used random sampling in those audits, and the standards applied were the ICD-10 2025 CMS, our PCS, CPT, and CMS and payer-specific guidelines. Of the 150 inpatient cases that were reviewed, we found that they were 95% accuracy. In the realm of DRG accuracy rate, we were at 94.8%. For outpatient, the accuracy rate was 97%. Key findings from the inpatient side, we found that 7 instances of incorrect principal diagnosis assignment. Those did not have any impact on those instances did not have impact on the DRG payments. With our outpatient side, we found that there were several instances where modifiers were not being applied appropriately, mainly the Q7 and Q9. Those are related to podiatry, foot care. We did provide education to the coders by way of review of ICD-10 CM coding guidelines and the definition of principal diagnoses and the hierarchy of sequencing. As well with the modifier, we did provide them a reference tip sheet on when those should be appended based on payer guidelines.
So these, I believe, are very good numbers. And for those of you not involved in clinical medicine, coders are very dependent upon providers to get the diagnoses right and include all the diagnoses. The biggest problem, I think, is undercoding. Having electronic medical record has helped with that, but it's still not done automatically. If a patient has a lot of comorbidities, somebody's got to recognize that and put it in there, and a lot of it is educating the providers to get this in their medical records so the coders can get everything in there. So this, there's been a lot of emphasis on this over the last 15 or 20 years, and I'm pretty sure when we started looking at this in my practice, we were not at 95%. We might have been at 50%. So a lot of progress has been made in that area. Any questions for Ms. Wood? Thank you.
Thank you.
Next, excluded vendor and provider checks. Angela Jefferson, Compliance Coordinator.
Good afternoon, Board. 792 vendors and 218 providers were submitted for vendor exclusion checks. None of the vendors that NGH uses were listed on the vendor exclusion list. For providers, 210 were not listed. However, 8 did come back for review, so we have submitted those for resubmission for exclusion checks. Are there any questions about exclusion checks?
Would you explain why vendors might be excluded and what that list looks like?
Yes. So this is for our NGH vendors and providers. So we submit through a board-approved third-party vendor, Ethico, who takes a list of our current vendors as well as our providers and checks them for any exclusions with Medicaid, any type of duplication, anything that would red flag them from us desiring to use them. This is a quick turnaround time, so we submit monthly, usually around the 15th of each month, through a macro embedded template that's provided by Ethico that uploads into a secure system, and they give us a turnaround time with these exclusion results within a week. But it's basically to safeguard our organization against potential people and companies who we may not want to partner with.
So vendors who are on the exclusion list might be companies who have not been compliant with
Correct.
payers.
Correct.
Playing by the rules.
Yes, sir.
And occasionally providers are excluded for
Right, may have an
violation of
exclusion with a
rules.
Medicaid or, yes, sir.
Right. Okay. All right. And I think that we actually approved a contract for this not too long ago, and it's
That was correct in May.
being very effective. Okay, and you can also discuss conflict of interest.
Yes, sir. So we submit a conflict of interest disclosure form. As of August, 100% of our hospital authority board has submitted the disclosure form. As of October 6th, 81% of internal leadership have completed the disclosure form, with a remaining of 17% that we're still waiting on. Any
right.
questions regarding conflict of interest? Yes, ma'am.
This is the form that I know Christy Lewis had worked on. Just out of curiosity, what was the kind of end date and time frame? I'm just curious as to why we have leadership who are still outstanding.
That's a great question. So we gave them an end date of October 8th. We did extend it during the window that we originally submitted it. We learned that the list of leaders that we received, some leaders had terminated from the organization, some leaders, one in particular is on maternity leave. So we just had some that were just out during that time frame. So we have allowed them to come back in to complete it. This is just as the date of this report.
Understood. Yeah, because I think that is really important for 100% of leadership to have this done, if we're going to ask all staff to do it. Thank you.
Any other questions?
Thank you. Ms. Jefferson. Next in the general reporting category, starting with the pharmacy 340B compliance program. Dr. Dick.
Thank you. Board. So this report is going to be about our 340B program. It's going to be split between compliance and with some savings information as well. This first slide is on our compliance audits. So the company, we actually just approved this contract this past board meeting sir.
Could you start by explaining what 340B
I'm sorry. Yes,
Is-
sir, absolutely. 340B is a federal program that allows us to purchase medications at a significantly reduced rate based upon usage. So for patients that we see who qualify for 340B based upon different criteria, who are seen by providers, that there's multiple different pieces of criteria there, then we are allowed to purchase medications at a much lower rates than our other medications to allow us, according to the program, to be able to provide for a wider number of different patients.
Thank you.
No, thank you. Great question. Part of these compliance updates, as you know, I just actually mentioned, is there's lots of different pieces that go into this. The patients have to qualify, the providers have to qualify, the visit has to qualify, the medication has to qualify. If all these things put together qualify, then we're allowed to then get what's called an accumulation that then builds up for us to be in the next time we purchase that medication, we can then purchase it under 340B. So with that, there's lots of different pieces that need to be in compliance. This company, Davidson, that we just approved this past board meeting, does these audits for us. And they go through all these different pieces of criteria. They do random audits of different medications that we've purchased under 340B to make sure that we have all of our ducks in a row for that. And so far, this year, we have not had any findings. We did this this financial year. We did this past financial year, but so far it's been a lot better. Next slide, please. These next pieces are different programs that we're involved in to help make sure that we, and the compliance part of that, because that's a huge part of whenever we engage in something new. With 340B, we have to be completely compliant with that. First piece is Carvin. So Carvin is where we are able to include Medicaid patients. But part of that, though, is making sure that we have lots of different pieces, including how we submit claims to Medicaid, to TennCare, because we cannot double dip. Right now, if there are lots of rebates and things that we can get under 340B if we exclude, it's called carve outs. But once we carve in, we actually get a lot of savings from that, but then we have to also do a lot of things in the back end to help make sure that we're not double dipping. And so currently we are, that it says it's in progress. We've actually completed the carve-in process that started when we went live with Cerner. Actually, January the 1st is when that went live. And so far, we have, at least on the inpatient side, we have been completely in carve-in. On the outpatient side, for our the specialty pharmacy, we've carved in for there, but we're still waiting on some things. There's some issues that we're having from the outpatient side on the standard claims that we submit. For our providers, we do audits on our providers. We actually have, with our meeting once a month, we have Teresa from Provider Services come in and make sure that any providers that we bring on board or that leave, that we are either including or excluding respectively those providers. Next slide, please. Written locations. This is also something that provides, we audit to make sure that all the different locations we have here, not just the hospital, but all the different clinics and the providers that we see there are in compliance. That's another step of compliance. Specialty pharmacy, this is actually a relatively new one. We actually have implemented the specialty pharmacy, and so there's lots of pieces with that as well. We have completed compliance checks with that as well. There at the bottom is a credit rebill of WAC purchases. I'll get into what WAC is in just a second, but that is also, we're in the process of trying to reclaim about a total of about $800,000. So when we went live with Cerner, unfortunately, there were some reports and things that we were assured were going to be in place and working correctly to be able to report correctly to a program, a third party that aggregates all this compliance information, and it didn't work, of course, to go live. So we spent the next about 4.5 months building this report with Cerner, getting it live, testing it, and then actually going live around the 1st of May. And that's, but because of that lag time there were a lot of things we had to purchase on the maximum price. So we're trying to go back and recoup those costs. And so far we've recouped about almost $500,000. Next slide, please. I'm going to go into some savings information now and a little bit of terminology to go with that. Pharmacy purchases medications, at least the inpatient pharmacy purchases medications under 3 different accounts. We have WAC, which is the wholesaler, it's basically the maximum cost that we could purchase for that medication. Whenever we first purchase anything in the inpatient pharmacy, it's always purchased at the maximum cost. However, because of 340B, we're able to then create we're able to aggregate accumulations, which therefore allows us to be able to the next time purchase that medication at a much reduced cost. We get those again by having the right patient, under the right insurance, the right provider. Everything has to line up so that the next time we purchase it, it's a lot cheaper. And so that would either go into a bucket for 340B or GPO. GPO is for our inpatient, 340B is for our outpatient. Next slide, please. So our goal is to reduce our WAC spend. And so you can see over the past, since 23, 24, and then 25, our total WAC spend has gone down significantly. So our total purchases, what we purchase in the pharmacy, is really dependent upon patient volume. And so the more patients we see, the more we're purchasing, which is great. However, we want to make sure that what we're purchasing is purchased at the lowest possible cost to get the maximum savings and the maximum margin for our hospital. Next slide, please.
What is WAC?
WAC is wholesaler acquisition cost.
Thank you.
Historical savings, you can see that over the course of time, at least since I've been here, I started here in 2020, our savings have been steadily increasing. You can see in 2025, we had a bit of a dip there. And then 2026 is our projected. That dip there is because of the issue that we had there with Cerner. So some of our savings there weren't quite realized. We are getting some money back from that. Next slide, please. I just want to kind of illustrate here specifically inpatient spend. As you can see here at the bottom, the percent WAC, GPO, and 340B is really where I want to focus in on. The total cost, again, is based upon how much we're spending because of what our volume is. Most of that is come from our infusion center volume. But you can see there at the bottom, but when we were in March and April and May, when we were having issues with all of our issues with Cerner, that our WAC spend was around 62%, 83%. But since that has been, we've got that issue fixed, we're below 20% for the last 4 months. Which is about where we want to be for WAC spend. Now, as far as GPO and 340B, that's always going to be split based upon if they're inpatient or outpatient. There's not really a way to do one versus the other. Next slide, please. Total savings, which is really the good slide here, is showing our savings over time. Again, we were having issues with Cerner, so that's where some of these savings dipped a bit into the negative there. But you can see August, a lot of that is from where we were getting some of that money back because of the credit rebills when we were getting everything resolved with McKesson from the Cerner issues. Next slide, please. Current projects is we are currently working on signing up contract pharmacies. This is something that most 340B organizations do to help bring in more money. Essentially, patients who are getting their prescriptions filled at other pharmacies, usually at specialty pharmacies, we're losing out on that. So what happens is those pharmacies that are filling those prescriptions, we contract with them. And so that money, the difference, and they get their money, that pharmacy does, but then the difference there, we actually get that back because we're seeing those are our patients and our providers. And so we just went live with these contract pharmacies. And so we're going to start seeing that money come in, hopefully very soon. Again, that's something big that Vasan, this is kind of a chart, a very busy chart that shows kind of how that money flows. Next slide, please. Contract pharmacy, again, this is more information about contract pharmacies. Next slide. The next project is not as happy of a project. It's called the rebate pilot. So 340B currently, I know there was, I saw advertisements and I saw different things about how bad 340B is. And so some of the pushback from manufacturers really don't want to be a part of this program. They lose profits because of being part of this program. So one of the ways that they have pushed back and that Congress has been allowing this to happen is by making it so that instead of us getting a direct, basically able to purchase it on a cheaper price, we had to purchase everything for these particular medications on WAC and then go through a rebate process with the manufacturer, which puts a lot more work on us as the pharmacy to be able to get that money back. This is not in effect yet. But it will be, that this is currently, it says here, HRSA has issued a notice about this to the Federal Register, and that's where we got information about this. This will probably go into effect sometime this next year, unless something big happens. Next slide, please. Any questions? That's a lot of information.
So that is a lot of information, but these programs, I've learned more about it recently, spending time with Dr. Dick, but these programs are incredibly important. You can see that they allow us to save a lot of money in purchasing drugs, but what that does is allow us to provide drugs to people who couldn't otherwise afford them. Chemotherapy drugs, some of these expensive anti-inflammatories and things that we otherwise couldn't provide to our patients. And 340B is tricky. You have to be right on target, playing by the rules. My understanding is some of the larger hospitals in the city are kind of on and off of 340B because they don't do what Dr. Dick has done to make sure that we're in full compliance. It's a really important part for any hospital, but particularly for a hospital like ours. And so I really appreciate the work that you've done there.
I have a great team.
It's evidenced by the progress you've made over just the last 6 months. It's amazing. And, of course, we're all happy to see the pharmaceutical industry help us in this, whether they're willing or not.
Yeah.
So that's pretty great.
Yes, sir.
Any other questions or comments about these?
Just to mention that this is very helpful for some of our patients with hypertension. I know I see a fair amount of homeless patients who come and we're able to, I know for a fact, amlodipine and losartan. These are very good blood pressure pills, and I'm able to get it for patients who are homeless for free. All they have to do is show up every month.
That's actually specifically because of our Hope Meds program.
Yeah.
And actually the pharmacy manager there is going to be presenting on that, not this coming board meeting, but the next one. That has been a humongous blessing to this hospital and to our patients.
Yeah, it's a big deal. Thank you.
It is.
I guess my other comment, again, is in the board meetings, we approve contract after contract that helps us with surveillance and compliance. And we did Visanti not too long ago and spent not insignificant amount of money on that. But, this is something that's really paid off, not only for the hospital bottom line, but for our patients.
Yes, sir.
Thank you again.
Thank you.
Next, a report on human resources. Ms. Walford.
Good afternoon, board members. We're going to talk about terminations and exit interviews. It's something that is important to the board. But before, I would like to let you know I have part of my team here who actually complete these exit interviews with physicians and employees who term. And so Delonda Payne is the director, and Brittany Starling is the one who actually does them. So we do them face to face. I want to make sure you see the people that are sitting there. We give every employee an opportunity to be able to sit down and talk to our team about their environment and what happens in the environment before they exit the organization. We do that, first of all, for service recovery. If we can recover them, retain them, maybe there's something we don't know. And so as they go through the questionnaire and we find out that there's something that we might not be aware of, then we give that feedback back. But ultimately, we need to know what's wrong in the environment so we can fix it. So what you see before you is a synopsis of January through September. I believe in the February or March board meeting, there was a request or a question whether or not we did physicians. So we've had 4 physicians leave, and out of 4 physicians leaving in this time period, 100% of them actually completed an exit interview with us face to face. In those exit interviews, we found out some very specific information to make changes in our environment. So the feedback was very beneficial. And in fact, one of the physicians actually ended up going PRN instead of just removing himself entirely from the organization because he had an opportunity to express his views. So the importance of these are very important. Now, our goal right now, if you look at the graph, is between 45 and 50% that we do recover. Because you have authorized our UKG system, which I'm so excited about in the future, we'll be able to have more real-time understanding of when someone has submitted a termination. Right now, it's word of mouth when we find out, or a piece of paper. So we try to get those exit interviews in as quickly as possible. So we believe that once UKG is implemented and that's put into an electronic system, it will automate and give us we'll build it that way, to give us a check to be able to say, go touch that employee, because we know that once a person leaves the environment, it's very difficult for them to fill out an exit interview. We just don't get the response. But when they're in the environment, they're willing to come down and sit with us or fill out paper. So just wanted you to see that. And I'm happy to answer any questions that the board might have about the process, or if you have any questions for Brittany about her experience with doing the exit interviews, we're happy to facilitate that at this time.
Any questions for Diana? Okay, thank you very much.
I had a quick question.
Okay.
Sorry.
Sure.
So you're saying that the current process, not the new EKG system, is been paper-based or word of mouth? Or what
Yes,
somebody
so
comes in and
what
says, hey, Rebecca or maybe Yolanda terminated or quit this week or today. How does that, walk me through that process?
Okay. So the department gets a notice that someone's leaving. And so their responsibility in that process is to let us know as well. So they fill out a status change form, which is the only paper process that we currently have. And then they also have to fill out a form to do our position control. And so we have a position control piece. If you want that position to be reposted, you must give us both documents. So where I talk about the technology is if the leader is on vacation or they forget to give it to us, so our timeline runs shorter. We end up getting it, but instead of having the whole 2-week period, we end up maybe having 3 or 4 days if it's not followed. So our goal is to increase the number of exit interviews we have by using the technology that's in the future. Now, I can tell you that previously, because we put some other things in place to, make sure that we're trying to capture as many as we can, by reminding folks that when they submit a status change form, to immediately let us know, to submit it, so not to wait, because that then triggers the rest of the offboarding process. But it's not perfect at this point because it's reliable on the human behavior instead of just having technology do it. So, but we do, the moment we find out, the physicians are a little bit different, and this is because they have to give a 90-day notice. So we find out, we meet with them, we talk with them, we go wherever they're at. So it gives us a little bit more time. But most employees within our environment give a 2-week notice and then they're gone. And sometimes that's really a short window between holidays and other things that people, when there's time off. Does that make sense? Or a leader has time off?
Yeah, and also maybe to follow up on that, so I'm glad that process, it feels very laborious and fraught with potential delays and potential errors. So I'm glad that the process is getting fixed. The other question I have was in terms of consistent themes that these two wonderful ladies are seeing, and we don't have to discuss this now, but I think that would be helpful to make sure that Dr. Martin or the board becomes aware of if there's ongoing things. I'm sure Dr. Elders as well, but and how that might have changed over time, and if there's any kind of feedback that they could give that would help us be thoughtful about how we set up priorities or giving that feedback to the different lines of businesses, the ELT, I think that would be helpful too.
Absolutely.
Perhaps at the next meeting, you could give us some examples of things that we've learned and changes that we've been able to make because of that?
Absolutely. We do have feedback. Sometimes we have what's called a compliance question on the form itself, but under there, they don't actually put compliance thing. They put things that are happening within their division. And if it's about the leader, then we give the information to the leader above so that they're aware that they're truly leaving because of leadership. We use Quentin Studer principles. We understand that a lot of times people don't leave our environment, they leave the leader. So we make sure that the leader above them also knows that as well. But we're happy to track that to say, hey, the last month we did this many, and this many people left because they said it was a potential with leadership. No problem in doing that as well. Happy to do it.
Okay, thank you.
Thank you.
And now to the compliance section of the Compliance Committee. Ms. Lewis.
Good afternoon. My name is Christy Lewis. I'm your Chief Compliance Officer, and I will start with the risk assessment, which should be on page 30 of your packet. Now, the Office of Inspector General and Health and Human Services provides a guidance that states that any healthcare entity should conduct risk assessments on at least an annual basis. Ours are done annually, and it is a dynamic document, meaning that we do we do have both forms that we are asking individuals to complete, and we also speak with our employees so that we are entering risk assessments that are done. Here we have a heat map, basically, that shows the highs and the lows, and it gives the risk scores. I will explain the heat map on there. To your left, there is a probability, which is the likelihood of an identified risk, the likelihood that it would occur. 1 meaning not very likely, 10 meaning that it's probably happening right now. The second thing is the potential impact. Is it a reputational impact? Is it a fiscal impact? How great of an impact that is? Is it a minimal impact, 1, rating of a 1? Is it a maximum impact, a rating of 10? And so what we have done is that we've taken the average of a score and we've given it a weighted times 10, and that's how we are getting the numbers that we've received on here. So for our risk scores, we had 4 that were identified as 100, 3 that were identified as 95, and we have 2 risks identified with a score of 80, 8 that were identified as a score of 75, 2 identified with risk scores of 70, and 1 identified with a risk score of 60, 65. To give you that prioritizes the importance of the risks that we need to address. And as we're stating, it's a dynamic document. So as we continue to get feedback from our employees and our leadership, we will add them, adjust them, and adjust the risks accordingly. So this is an ongoing document.
So, sorry, but could you tell us, like, for example, these 2 spots on the graph that have the highest probability and highest potential impact, what would they be?
What would they be?
Yeah.
So for one of the ones that was identified is that, let's say for one that was identified with a 100% score, let's say there was a PA system that's not working on one of the floors. And so we are in the process of addressing that. Right now we have bids in to select a vendor to undergo that, so that we will submit that contract. That's one example of ones that was submitted that had a 100% score. One that was submitted, another one that may have been submitted that had a 100% score is that the board recently approved a new keying system under our capital expenditure. And so we want to make sure that we have policies in place so that when we have people who are leaving or people who are terminating, that we want to make sure that we keep those keys for security purposes and reasons. Those are the types of things that were identified and scored. Again, the individual who is submitting the risk is the subject matter expert, and we rely on the submissions that they have for weighting it, for the importance of it for the hospital. That also gives us the prioritization and the urgency of how we need to address that.
Thank you.
Thank you. I will then proceed with the next thing is the compliance work plan, which is on page 32 of your workbook. Compliance work plan, again, is something that is done on an annual basis, and it too is a dynamic document. It is the risk assessment entries that we receive feed the compliance work plan, in addition to other responsibilities that our leaders are supposed to do on an annual basis. An example that we have in the compliance is to conduct monthly vendor and exclusion lists. That is a regulatory compliance, and it is also guidance that we receive from the Health and Human Services. To give you an example, so in this compliance work plan, we do have some accomplishments that have been done since the implementation of this internal compliance committee. We want to show you that we have completed, of course, the hospital-wide assessment, which is an ongoing document. We have revised the conflict of interest policy, and we have disseminated that to our leaders. We're in the process of completing that with 100% completion. We look forward to reporting to that in the next reporting cycle. We have addressed all findings in the 2025 audit that was submitted in February of this year. All findings have been addressed and resolved. We have revised hotline tracking and conducted a poster campaign to improve the awareness of that and to ensure that people understand their obligations to report. We have conducted a monthly phishing training exercises courtesy of our information security from Mr. Andy Leffler. We formally implemented the intelligent contract system and management system in response to the auditing findings, and we have maintained our A leapfrog rating courtesy of our quality department. So those are some of the accomplishments that we've received or we have done during this reporting period. We wanted to make sure that we have 45%, 25% are one-time items that have been completed. We do have the remaining 16% are ongoing. Again, an example is the monthly vendor checks. That's ongoing. We want to make sure that we acknowledge the distinction between something that is one and done versus something that is continuous. So right now, we have a 45% completion rate for our compliance work plan. Are there any questions regarding it? Okay. I will go ahead and proceed to the next thing dealing with our compliance and reporting, was dealing with our Tennessee Department of Health surveys. We have received a total of 8 Tennessee Department of Health surveys, and that's based on our self-reporting for serious safety incidents. Of those 8 surveys, only 1 had a conditional finding. And very pleased to say that the hospital as well as the quality department have collaborated very closely to address those immediately. So policies have been updated to address what we have learned and worked with the Tennessee Department of Corrections. We have also implemented 2 sets of trainings, one that has had 100% completion. The other one that we have initiated is still under completion with the PowerPoint, and we are docking that with attestations and acknowledgments as well. And we have also disseminated all of that patient as well. Now, this finding on which we have done extensive work, we have just recently learned that it will be reopened. So we anticipate having a surveyor to come out to speak with us regarding that. But we have done all that has been required at this point to address the matter as expeditiously and thoroughly as possible. In the next part of it, are there any questions? Sorry. No questions? Okay. The next part that we have is the incident management reporting. This is what we commonly call the hotline or the helpline. And this is a part of our code of conduct that says that all employees, vendors, staff members, anyone with whom we are doing business has the obligation and the duty to report anything, any question, any concern, any policy violation, any culture concern, anything of that nature. If you see something, you want to say something, say it. And say it to us. Say it to us first. Say it to us. It is our obligation to respond and to respond promptly. And in that, we have had a poster campaign to ensure that people are understanding their duties to report and to understand that they should be free from retaliation if they choose to report. So we want to make sure that that is ongoing. And to date, we have had 3 incidents that in this reporting period. We have been identifying for 2 of them that have been substantiated and have been closed. We give the benchmark standard is 30 days to review investigations and to close them. 2 have been substantiated and resolved. One is still ongoing because there's an additional investigation, and we have documented as to why that is still open, and we have an estimated time for completion. So we are picking up that number. We intend to pick up that number even more as we continue with the campaign. Are there any questions regarding incident management?
The first two that have been completed, were they completed by having an action plan to improve something, or were they completed to the satisfaction of the reporting people?
Yeah, okay, one of each, yes. The question is one of each. The two that were substantiated, one, there was an action plan. There was a question regarding a particular policy and its application. We did triage with that particular department leader to make sure that there was explanation that was done, to make sure that there was targeted training that was performed, and to make sure that the person in question was able to sign off on that policy and have that placed in their file to ensure that there was consistency and understanding and application. On the second, we received a call. There was a question about regarding termination, and they wanted to speak with HR about that as well. HR received it, responded very quickly to that person, and has met with that person to the satisfaction that the termination still stands. And so that's what we call the things have been substantiated and actions have been taken. The second one was completed within 15 days. The first one was completed within 12 days.
Good. All right, we can move ahead.
Okay. On the last area that I want to discuss is about litigation reporting, and of course this is a risk area. Of course, that's why we are bringing it here. To date, we do have 7 open cases. We have 2 breaches of contract, 1 medical malpractice, 1 slip and fall, 1 personal injury. We have 1 investigation and 1 EEOC case. And it looked like to say, as of this morning, for 1 of those breaches of contract, that case has been dismissed without prejudice, meaning that the opposing counsel could refile. Again, we learned that information today. So actually now we have 1 breach of contract that is standing. For the medical malpractice, the board has been apprised of that case. And also for the slip and fall, we have received additional action on that this morning. For investigation, we have our investigation, our due date for submitting all of the information has been extended to October 30th. And for our EEOC, understand that we are working with Metro Legal, and they are looking at December dates for mediation.
Okay. Thank you. And I will say that the cases of significance have been reported to the board and discussed with legal counsel in other settings. And if there is interest in any of these others, board members are welcome to speak to Mrs. Lewis for the details. Any questions about litigation reporting, or any other questions for Ms. Lewis' thorough report? Thank you very much.
Okay, thank you. I'd like to thank the support of Dr. Elders, and as well as the Compliance Committee and Quality, and everyone else who has submitted reports. Thank you, thank you, thank you. We do appreciate all of the hard work that were done to make the Compliance Committee great. Thank you.
Thanks for all the work put into this, which has been going on behind the scenes, and we're grateful to know about it. Is there any other business to come before this committee? If not, I will ask for a motion for adjournment.
Make a motion for adjournment.
And a second. Second. All in favor?
Aye.
Aye. Meeting adjourned. Thank you.
This has been a service of the Metro Nashville Network. If you would like to see this presentation again, or for more information on this and other programs, visit nashville.gov.